Today's class is basically on cephalosporins, and I think you have already had your discussion on penicillins. So cephalosporins are basically will be become very easy if you see if you remember penicillins. So in the light of that, we'll start with these cephalosporins, and by the end of this class, you should be able to discuss and remember and understand these things. First of and foremost is what is the place of cephalosporin in antimicrobial therapy? It is one of the important aspect because to choose an antibiotic or antimicrobial from a given list of a lot of antimicrobials is important. Now, if you are choosing cephalosporins, you have to choose between different generations. So cephalosporins have different generations from 1 to 5, and that you have to choose between them. You have to understand what is the difference between these cephalosporins, a different generation of cephalosporins, and what is the basic spectrum of these cephalosporins, uh, and then you can actually understand where to use them. The third one is to understand the mechanism of action and indications of cephalosporins, and finally, what are the major adverse drug reactions of these cephalosporins. So, in the middle of somewhere, we will also discuss some important drug interactions or some part of this resistance as well. But this is the most important points, and you should be able to understand all these points at the end of this class. So to start with, cephalosporins are basically beta-lactam antibiotics. When I say beta-lactam, that means they have beta-lactam ring. So other antimicrobial which have these beta-lactam rings is the penicillins. And therefore, when we say that they are similar to penicillins, that means their spectrum is also quite similar to penicillins, especially the first generation of penicillins. So they are actually broad spectrum, but we'll discuss about this spectrum more in the later class, because this spectrum actually differs from the first generation to the fifth generation, and we'll try to understand which generation will have which kind of spectrum. But broadly speaking, most of the first generations will have a spectrum very similar to penicillins. Then, as the penicillins, these are also cause inhibition of cell wall synthesis. And when they do inhibit the cell wall synthesis, you know that cell wall is important part to regulate the osmosis between the cell and the environment, and therefore when they inhibit the cell wall synthesis or disturb the cell wall synthesis, there is a chance that the cell might die because of the disruption of this osmosis. So basically they are bactericidal. They require a large time to act. It's not very important that they have a very high concentration in and around the cell or the bacteria, but they require a large time effect. So they are basically time dependent killing. They're doing a time dependent killing. So they are bactericidal. They are doing time dependent killing. They inhibiting the cell wall synthesis, and therefore they are broad spectrum, very similar to penicillins. So so they are basically derived from Cephalosporium, from which it derives its name, cephalosporins. So very interesting story about that. It was actually an Italian pharmacologist who are actually searching for different molds after the discovery of penicillin to actually inhibit typhoid bacterium. So he was actually doing a lot of surveying. So lastly, he went to a sewerage pool, and there he find out this cephalosporium, and it was was actually very effective against these bacteria. So from there, from that part, Italy in 1945, I think it discovered. He discovered, and then in 1960s it came to the market. Since then, it has been used. Initially, they were only one generation. Then again, many generations they actually came. Now we have fifth generation cephalosporins. Uh, Basic structure, you can see that it also has the beta lactam ring. What it differs is that it also has this side chain at the dihydrothiazine ring. This is the main difference between cephalosporins uh, and the penicillins. I don't want you to remember this structure. What I want to emphasize is these two these two carbon atoms, and I will tell you why these are important. These first is a C carbon atom in beta lactam. It's position 7, and in this dihydrothiazine ring at position 3. Now, if we change the side chain in this carbon atoms, it will produce a different kind of cephalosporins, which will have a different kind of activity. So, for example, if we change the carbon atom at position 7, the spectrum uh, of the newer cephalosporin which is produced is greatly changed. So it might have more activity against pseudomonas or gram negative bacteria, or it may have activity against MRSA. So all these things are happening because of the change in the C carbon 7 in the beta lactam ring. Similarly, um, at the carbon 3 of this dihydrothiazine ring, if we change that, we can change the pharmacokinetics. So basically, the pharmacokinetics of the first generation, the first produced cephalosporin, is that they were given through parental route. So to change the parental route or to change the half-life, it is required to to change the side chain at this carbon atom. So why this is important? Because we knew this, and we tried to alter these side chain at these 3 and 7 carbon atoms, and therefore a huge number of cephalosporins are produced. I have already told you that they are from 1 to 5 generations, but in each generation there are a lot of cephalosporins, and I mean it is truly very hard to remember all these cephalosporins in one generation. So a lot of cephalosporins are produced. You can see the generations here. In the first generation, cefazolin is a very important drug, and it is used for surgical prophylaxis. Second generation, sulfoxamine is good. Third generation, ceftriaxone is there, and cefoprotaxime is there for oral administration, which is very commonly used. Cefepime in fourth generation, and fifth generation, biperol and ceftriaxone. These are the two fifth generation cephalosporins that are there. Apart, this list is very small. There are a lot of antimicrobials, cephalosporin, which are also there, and this is very long list. So how do these generation differ? That is the main question. So as we go from first generation to the first generation, are basically like penicillin. They have very good activity against gram-positive bacteria. So as and when the newer generation they start coming, the scientists wanted to make a cephalosporin which has gram-negative activity also. They have the first generation had the gram negative activity, but it was very narrow spectrum gram negative activity. So to broaden the spectrum, the gram-negative, to increase the gram-negative activity, the second generation and third generation were produced. So the gram-positive activity, but when while doing that, what happened? The gram-positive activity was going down. So if you see the spectrum, if you see the spectrum, the gram-positive activity actually increases from the first to at least third generation. As a rule, there are some exceptions, but the gram-negative, gram-positive activity is being decreased from first to third generation, while the gram-negative activity is increased from the first to third generation. Now, in the fourth generation, they have pretty good gram-negative as well as gram-positive activity. Even gram-positive activity is even better than the some of the third generation activity. So the fourth generation has a very good gram-positive and gram-negative activity. Some of these also have in the third generation also have a spectrum of activity against pseudomonas also, which is a very important aspect of these antimicrobials, because to treat that pseudomonal infection is very tough, and a lot of clinical acumen has to go into that. So therefore, pseudomonal activity in third generation is a very important factor. Then in the fifth generation, what happened that after having this in the 90s and the early 2000, it was found out that a lot of bacteria are becoming MRSA, that is the methylation resistant. So because of that, uh, it was required to uh, search for the cephalosporins, which are basically has activity on MRSA. So therefore, the fifth generation is basically a third generation, has an activity of third generation, plus it also has the activity of MRSA. To some extent, it also has activity against one of them has the activity against pseudomonas also. So if you see this whole chart, then you can find out that the gram positive activity is very good in the first generation. It decreased up till third generation. Fourth generation has a very good gram positive activity, while the fifth generation has a very good activity against even against the methyl resistant Staph aureus. So therefore, uh, the gram activity is firstly increased, and then fourth generation has positive better activity, good activity of gram positive as well as gram negative, and the gram negative activity is increasing from first generation to fifth generation. Now there's one more aspect of this, that is the degradation by the beta lactamases. So again, like the gram negative activity, the sensitivity towards the beta lactamases is also decreasing, which is a good thing, because we don't need the beta lactamase inhibitor to in many of them. So so beta lactamase sensitivity is also decreasing from first to fifth generation. So that is the major differences between them. We'll go with the through the each generation separately, and then we'll be able to understand what is the basic indication of them. So if we see the mechanism, you already had the class on penicillin, so you already have some idea about the mechanisms. Uh, so basically, what the gram positive, especially the gram positive organisms, they require uh, a coating. That coating is of peptidoglycan. The peptidoglycan is made up of two important parts, that is the NAM and NAG, and acetyl muric acid and acetyl glucosamine. And this NAM and NAG are important because they form the building block of this peptidoglycan outer coating. These are connected through these chains of this peptide chain. These are basically synthesized in the cell, and the NAG is then attached to it, the NAM, and finally they are produced. They are thrown out of the cell, and they form the peptidoglycan monomer. Whenever there is some problem or some defect in the NAM-NAG chain, then autolysis they degrade this the defected part, and these NAM-NAG monomers then get attached to the to this peptidoglycan chain with the help of transglycosidases. Now to produce the cross linkages, there's another protein which is required, which is the transpeptidases. These transpeptidases are important because our penicillins or our cephalosporins, they go and bind to this transpeptidases, and these transpeptidases are required to make this peptide bond. When the peptide bond is not produced, then the cell outer layer is degraded, and the cell is more likely to be dead because of the autolysis. So, to essentially the like penicillins, they their spectrum is basically their mechanism is basically to inhibit the transpeptidases. Basically, they bind to the penicillin binding protein at a different site, and therefore causing inhibition of the activity of transpeptidases. And therefore, when transpeptidases are inhibited, then the formation of the cross linkages between the vector glycan monomers are not there, and because of that, the cell is more prone to osmotic injury, and therefore when this happens, the cell lyses, and therefore they are bactericidal. Now, as I told you that at carbon 2, uh, that can alter the pharmacokinetics. So these cephalosporins, they have very diverse pharmacokinetics. Each and every drug has some sort of difference in pharmacokinetics. They cannot be a generalized rule. Usually, there is not a generalized rule for them, but we can see an overview that most of the drugs of cephalosporins, they are given by parenterally. Usually the fourth and fifth group, they are usually given parentally. Apart from that, third generation, second and first generation are also given orally. This is important because in patients who are ambulatory or who are on a daycare surgery, daycare, they can be given oral antibiotics also. Uh, the good thing is that they're um, uh, they distributed all across the body, even in the CSF, and they achieve very high levels in the pleural, pericardial, peritoneal, and synovial fluids. That means they can be used for any respiratory infection, especially in the lower respiratory tract. They are very effective. They can also be given in the upper respiratory tract infection also. Then septicemia or nephritis or uh, uh, any infection of any organ, it can be used to treat those infections because it has a very high uh, penetration power. It can also be used it has good concentration in the urine, so because of that, it can also be used in urinary tract infection. Now, as I told you earlier, that it also penetrates CNS. So the thing is that the first and second generation, they have a very less penetrability. But if the meningeal irritation is there, uh, the membranes are a bit more. The cephalosporins can penetrate more through the meningeal inflamed meningeal membranes. Then we talk about the metabolism, and it is important because the metabolism, because of you are treating a very diverse. These are very um, broad spectrum antimicrobials, and when you're treating these kind of diverse patients, so some of the patients might come into kidney failure or hepatic failure, so you have to know whether the dose has to be adjusted or not. So most of them are not metabolized by liver. Therefore, in hepatic failure, you don't have to change the dose, but most of them are aspirated by the kidney. Therefore, in most cases, there has to be a change um, in the doses of these cephalosporins in patients with renal diseases. Not in the mild, but moderate to severe renal disease, their patient requires change in the dose. So one more important point is that these are not these drugs are not very good binding have very good binding to the plasma proteins, and therefore their half-life is very less, like 30 to 90 minutes, and therefore ceftriaxone become very important in this, and you will see in your clinical practice that you are going if the patient is hospitalized, you will be using ceftriaxone a lot because of this very high half-life and also very good spectrum of activity against the gram-negative bacteria. So we'll talk about this ceftriaxone, but you have to understand that it has one of the very high half-life uh, as compared to the other cephalosporins. So we start with the first generation cephalosporin. As I told you earlier, that they have a very narrow spectrum, mostly the gram-positive bacteria, that is the methicillin sensitive Staph aureus and beta hemolytic streptococcus. These are the main spectrum of their use. And secondly, they also has some activity against aerobic gram negatives like the protease E. coli, Klebsiella. These are called as PEC. Most of the cephalosporins have some activity against this PEC group, that is protease, E. coli, and Klebsiella group. But they do not have any activity against the enterococci or gut anaerobes. So remember that mnemonic called LAME. L stand for Listeria. Sorry. L stands for Listeria. A stands for atypical microbacteria or atypical bacteria. M is the MRSA, and E is the Enterobacter or Enterococci. So these bacteria are basically resistant to the to most of these cephalosporins. There are some minimal exceptions, but as a general rule, the LAME group is basically resistant to cephalosporins. Now, in a second generation, they have the coverage of the first generation. The coverage of gram-positive is similar. That is, the MRSA and Streptococcus are sensitive. Then gram negatives, they are active against the PEC group. Plus, they have also increased activity of on H. influenza and Moraxella. Then they have also some activity against the oral anaerobes. But again, they are not very active against the gut and anaerobes and enterococci. They are usually used in as a step down therapy for oral step down therapy for the CAP, that is the community acquired pneumonia, and the patient is ambulatory. Then you can go for switch from a IV third generation to a oral second generation. That is the most important factor in this therapy. Then the third generation, and perhaps the most commonly used drugs are of this third generation. And ceftriaxone, cefotaxime are, if you see that in our hospital and as well as in other hospitals, these are one of the most commonly used third generation cephalosporins. They have a broad spectrum. That means they will cover the gram positive. They have reasonably good coverage. It's not that good against like the first generation, but they have some coverage against the Staph aureus and the Staphylococcus. But the gram negative coverage has increased from the second generation, and now it includes the Neisseria meningitis and Neisseria gonorrhoeae, and oral anaerobes are also pretty much sensitive to this antimicrobial drugs. Again, they have no activity against Enterococcus and Pseudomonas. I'm telling here Pseudomonas because there are a few drugs in third generation which are going to have the activity of activity against Pseudomonas. Now we come to this another one, which is this ceftazidime. It is a as compared to ceftriaxone, it is less broad. The spectrum is lesser than the as compared to the ceftriaxone, and the gram positive coverage is not very good. But the thing is, because it has a very good coverage against Pseudomonas, it is very effective in treating the infections like septicemia or pneumonia caused by these Pseudomonas. It is usually given with the combination of aminoglycoside, which you will learn in future classes, and perhaps the first line of therapy against Pseudomonas. Why I'm saying Pseudomonas again is because it is very difficult to treat. Not many drugs can actually go and have spectrum against Pseudomonas. So having a generation cephalosporin against Pseudomonas is a boon to all the doctors in emergency and inpatient departments. Then again, one more is the cefixime. It is also a lesser spectrum. It covers again the coverage of the positive is poor, but the gram negative coverage is very good. And it has a spectrum against Neisseria gonorrhoeae also. Although it doesn't have that coverage against the lean and the Pseudomonas. In case of gonorrhea, we have to understand that there are better drugs also to treat the gonorrhea. Penicillins are also there, so it can also be treated with the third generation, as well as other antimicrobial also are there. Similarly, for typhoid, third generation cephalosporins are the drug of choice. They are very effective in typhoid fever, and intravenous route given by intravenous route, they are very effective in controlling and curing typhoid. Now we come to the fourth generation. As I told you earlier, that the fourth generation has a good spectrum against both gram positive and gram negative bacteria. Cefepime also has the um, also has a spectrum against these Pseudomonas bacteria. Again, they are not effective against the lean group of bacteria. Now we come to the fifth generation. Fifth generation is basically the third generation, plus they have some activity against the resistant bacteria. So if we see the activity of ceftriaxone, we can see that the activity against MRSA and MRSI then are very highly there, and it is very important because a lot of patients we're getting are having this MRSA, and it is very difficult to treat because of the resistance produced by these bacteria. And mind you, the resistance produced by this cephalosporin is very similar to the resistance produced by the penicillins. Most of the time it is because of the change in the of the proteins. Uh, Penicillin binding proteins. The efflux pump can also be changed. So these are the few of the few of the mechanism by which the MRSA is getting its resistance. So, but the thing is that they are not very effective against the Pseudomonas. But the other one, that is the biparole, which has somewhat decreased activity against MRSA, but it is effective against Pseudomonas. So if we talk about the adverse drug reaction, as with the penicillin, there is a chance of allergic reaction. Although it is much lesser than the cephalosporins, but there is a chance of allergic reaction. So we have to, when providing this, when administering this to our patient, we have to be careful about this. There is a chance of thrombophlebitis also. It is much rare, but it has some chances of thrombophlebitis. The diarrhea is more common with the oral cephalosporins. There is a chance also of nephritis because they are being excreted by the kidney, and therefore glomerulonephritis or tubular necrosis is can be there, especially when you are giving them with the high ceiling diuretics. There's a chance of neurotoxicity, and there is also chance of superinfection, especially with the fungal infection, and sometimes membranous colitis can also be there. There are few rare hematological toxicities are also there. That means sometimes in a very rare cases hypoprothambinemia is there, so the patient might be prone to bleeding. There's also a chance of neutropenia in some antimicrobials of cephalosporin group, but these are very rare adverse drug reaction. If we talk about the contraindications, um, contraindications are basically, we know that there is a cross reactivity with the penicillins. It was given that around 10% was there with the first generation. As the generation progressed, this cross reactivity become quite lesser and lesser, and now it is I think it is less than 1 or 2%. So, but there is a chance of cross reactivity, and we have to be very careful. It is not an absolute contraindication, but yes, it's a relative contraindication. There's a there's a chance of serum sickness like illness in children with less than 5 years, especially after second or third, fourth exposure. What it means is that, like in the vaccines nowadays, there's a sickness, there's a myalgia, rashes are there, some sort of allergic reactions are there, the arthralgia are there. So in this is the serum sickness like illnesses. It is more common with the cefaclor. If it is there, then it should not be given. Cefditorin is basically is used is a third generation cephalosporin. It causes increase secretion of carnitine from the kidney, and usually it has of no consequences. But in some patients which have the carnitine deficiency, in those case, patient it might cause this carnitine deficiency, and might lead to hypoglycemia, and sometimes may cause encephalitis also. So it is contraindicated in these patient which have inborn error of metabolism, especially with carnitine. And the last one is ceftriaxone. Ceftriaxone is basically contraindicated in hyperbilirubic units is in less than 28 years. It's because uh, the it competes with the bilirubin for the binding protein, and it displaces the bilirubin with a binding protein, and that bilirubin might go into central nervous system and can cause encephalopathy, and therefore ceftriaxone is basically not given before the age of 28 days in neonates. Now, as I told you that they are like penicillins, they are pretty safe. They are not category A, but because they crosses placenta. But in any case, they are very safe in pregnancy as compared to other other antimicrobials. We need a dose adjustment. We need dose adjustment uh, in all cephalosporins. I told you because they are being used, they are being excreted from the kidney, and therefore they are used in they are if you are using in a renal patient, then dose adjustment has to be there. One exception is of course ceftriaxone. Ceftriaxone is basically also excreted through bile. Some 30 to 60% is excreted through bile also. So therefore, the renal dose adjustment might not be required in ceftriaxone. So it is very good drug in renal patient. Uh, Finally, the hepatic dose adjustment is not required because most of the time, most of these drugs are not metabolized by liver, and therefore this adjustment is not required. So finally, we close this class just to remind that cephalosporins are like penicillins. They inhibit the transpeptidases enzymes because of the 2 and 5 and 7 and 2 carbon atoms, the side chain of the carbon atoms, which can be modified. There is a huge amount of cephalosporins in this group, and they have a spectrum of activity from gram positive in the first generation to the fifth generation. The activity of gram positive on the gram positive is decreasing. The gram positive the gram negative activity is increasing from first to third generation. Fourth generation is basically has a good gram negative as well as gram positive activity, and the fifth generation has an activity like the third generation, but it has more activity, or it has acquired the activity against the gram against the MRSA and MERSI. So that is that it covers the cephalosporins. If you have any questions, please do ask. Okay, if you have no question, then we can stop this class.